Thanks, Mark, for that very kind introduction. I have to start out by saying that I am actually the fill-in speaker to one of our colleagues from Uganda, Dr. Onkamo, who was unable to attend. And so the title was originally looking at hepatitis B vertical transmission in HIV positive individuals in the developing world, and I'm really not the ideal individual to speak to this, but I will hope to discuss this very, very important issue that affects us both locally and globally in this somewhat forgotten co-infection in the perinatal situation. So obviously these prior speakers have clearly reminded us of the significant proportion of the globe infected with hepatitis B and the coexistence also in many cases of HIV and hepatitis C. But I think what's important to touch on for this component is that about 5% of mothers globally are chronic hepatitis B carriers. And versions of this map have been presented already just to show the burden of disease again in particular areas of the globe that are also in many cases very high burden areas for HIV. It's also something that we see more than one might imagine in British Columbia here because of our immigration patterns and a very high number of individuals from Asian descent, and therefore we actually have quite a high burden of hepatitis B in this area of Canada. So we have, in some cases, 8% of our immigrants are hepatitis B positive. Our northern Inuit peoples have high rates of hepatitis B, but overall about 1%. So I put this graphic up, which is actually just a cartoon of timing of HIV transmission, which obviously has been the topic of this conference, and really has the natural biology of HIV in pregnancy is actually a great relief to us because the placenta forms an excellent barrier to HIV, resulting in the vast majority of transmission occurring in the peripartum period and in breastfeeding. And really the hepatitis B pattern of transmission can be overlaid on this, and again gives us the same opportunity of peripartum prevention and post-exposure prophylaxis type prevention for hepatitis B as well as for HIV. So transplacental transmission of hepatitis B is fortunately very rare. The vast majority of transmissions, as I'm sure you well know, occur around the time of delivery. And in contrast to HIV infection, breastfeeding, in fact, is not thought to be a major contributor to hepatitis B transmission. There is some risk of horizontal transmission in an infant in a household with hepatitis B positive individuals. And what's been highlighted earlier is, of course, the problem of infancy, which is if an infant acquires hepatitis B, they have a much higher rate of going on to chronic disease than if this disease is acquired in adolescent or adulthood. So prevention in the peripartum period becomes particularly important because of this. So the standard neonatal post-exposure prophylaxis program for hepatitis B monoinfection has been extremely efficient when used comprehensively. So hepatitis B immune globulin, passive vaccination delivered at less than 12 hours after the time of delivery has actually a very good short-term efficacy. Vaccine alone, initiating the vaccine series immediately after delivery also has good efficacy. But when you combine these two strategies of giving hepatitis B immune globulin plus the initial dose of the hepatitis B vaccine, followed by the second and third in the series, there is 85 to 95% efficacy in prevention of infant hepatitis B. However, it is important, and I'll come back to this, it is vital that that first dose be given immediately as opposed to later on in an infant series, as that's your window of opportunity to prevent peripartum transmission. And then depending on situations of prematurity, low birth weight, there may be an additional extra dose needed of the childhood vaccine series. I just thought I would take the opportunity to share a little bit of the BC data, which I think is really, I'm presenting to show that in the context of a high-resource setting with access to a public prevention program of HBV and hepatitis B vaccine, despite all of the resources we have in this context, we're actually seeing a situation where we're actually missing. So this is a review done by my colleague Julie Van Schalkwijk, where she looked at mother-infant pairs, 721 mother-infant pairs. We have about just under a 1% risk rate of hepatitis B surface antigen positivity in our pregnant women here in British Columbia, and about 22% of them are also hep B E antigen positive, and that, as I'll discuss in a minute, confers additional risk to the infant. What's extraordinary in our context, and we're working on this, let me tell you, is that 20% of our mother-infant pairs did not result in the infant getting the appropriate post-exposure prophylaxis as per guidelines, and we actually missed infant follow-up testing to ascertain whether or not there were escape infections in about 25%. The infants were, for the most part, fortunately negative, but we did have some transmissions, and in 7 cases, and 6 of them were of E antigen positive mothers. So we really felt this was a wake-up call in the context of a resource setting, which really we shouldn't have this at all. Now, what are the kind of factors associated with hepatitis B transmission in the mother-to-infant setting? And it really looks like, much like really the HIV story, it's related to maternal viremia, or level of hepatitis B DNA in maternal circulation. And so a number of studies have been done looking at levels of hepatitis B and whether or not there would be escape infections in the context of post-exposure prophylaxis. And what you can see here, I don't know if that doesn't show, that if you have less than 6 log 10 of DNA circulating, you actually have pretty much 100% prevention of transmission in the context of the post-exposure prophylaxis. But when you get up to higher rates of circulating virus, it's clearly not sufficient. And the question there, is it because of pre-delivery transmission or simply the level of virus overcoming both passive and active vaccines? So the thought is you may get as high as up to 30% transmission when you have over 1 times 10 to the 6 copies at the time of delivery. So in deference to our Ugandan colleague who was supposed to be giving this talk, I thought I would just review a little bit of the African data. It looks like when you look at our HIV positive pregnant women in a variety of both African, Thai, and South African reviews, you see in Nigeria about 4% of HIV positive pregnant women are co-infected with hepatitis B. Here is some Thai data showing that about 7% of their HIV positive women were co-infected with hep B surface antigen positive, and of those, about 50% were highly infectious and E antigen positive. And they were seeing, in fact, 4 to 6% levels of vertical transmission in this context. This is the situation where they're using their post-exposure prophylaxis is vaccine only, not HBV. And the question is the transmission related to escape mutations thought to be related to viral mutations in the mom, or is it level of virus? And it seems really, again, it's level of virus. If we look at some South African data, 189 HIV positive women studied, 7.4% hepatitis B co-infected, and the vast majority E antigen as well. In this case, they had a 28% transmission rate. But what I think is really important is their country recommendation was only to give the vaccine first dose for the infant at 1 month and no HBV. So you really aren't having post-exposure prophylaxis in this setting, presumably contributing to their higher rates of transmission. In the context of the HIV positive women, not all of them were on antiretroviral therapy, and those that were on lamivudine based, in part related to the time period. So That allows me to segue a little bit into the use of antenatal antiviral therapy for the prevention of hepatitis B vertical transmission. So in the monoinfected setting, so hepatitis B infected only, not HIV co-infected, there is actually some growing evidence that antenatal antiviral therapy may be appropriate to consider where the maternal hepatitis B viral load is very high. And in this case, that we're talking more than 2 times 10 to the 6 international units, or greater than 10 to the 7 copies per mil. So there are a number of trials looking at lamivudine monotherapy, telbivudine, and then a case series of tenofovir with a large RTC currently enrolling in Thailand, to my knowledge. So at the moment, for a variety of reasons that have been talked about earlier, tenofovir is definitely the preferred drug simply because of its genetic barrier to resistance. So then it brings up the question of the use of tenofovir in pregnancy, whether it be in the co-infected or mono-infected situation. And there's a great deal of variability in opinion on this data, but there is certainly some cause for concern in the use of tenofovir in pregnancy because of some possibility of inhibiting mineralization in forming bones, and the theoretical concern with regards to renal function, although we haven't seen that particular concern in the infants. But there is variable data. Some of it has been presented here, where we're seeing some decrease in bone mineral density in infants exposed to tenofovir in utero, and some concerns with regards to growth. Overall, it looks like most of this is reversible, but there's a continued effort to study this in a variety of centers to try and understand the real risks associated with tenofovir. So when we look at the situation of HIV and HBV co-infection, obviously combination antiretroviral therapy is recommended for HIV-positive moms. So in the context of co-infection, they're going to be hopefully on therapy. But the question is, what's your choice of therapy? Lamivudine-containing regimens has been discussed earlier, obviously present the risk of high rates of resistance. And so tenofovir-containing regimens, despite the concerns vis-a-vis the exposure in utero, would still be the preference for co-infected pregnant women. And advocacy for access to tenofovir in high-burden areas is really important. The other issue that needs to be considered is in countries that are not going with option B+, where they're continuing the moms on the antiretrovirals postpartum, where if you're stopping antiretrovirals in a situation where you've got a Hep B co-infected individual, there is the theoretical concern of hepatitis B or Hep B flare. So then the other thing that has really come up very recently, of course, is the option of TAF. And it looks like from what we're hearing at this meeting that TAF is clearly going to be a good alternative of a tenofovir, essentially tenofovir with low toxicity. One would think theoretically there probably isn't that it would be safe in pregnancy, but of course we have absolutely no data of the use of TAF in pregnancy yet, but it would be something definitely to be considered. I just want to briefly mention other obstetrical interventions that we utilize for prevention of transmission in some cases, and cesarean section is certainly a tool that we have to use to decrease HIV transmission in the context of access to cesarean section where appropriate antiretroviral therapy resulting in suppressed viral load has not been achievable during the pregnancy. So we're not going with cesarean section routinely, but with still using it in some cases. And then the question is, what about cesarean section for hepatitis B prevention? There's been several studies done over the years looking at this intervention, and really it appears that generally speaking, there is no added benefit to the cesarean section in prevention of vertical transmission, and only in a very, very high maternal viral load in the absence of post-exposure prophylaxis was it shown to be advantageous to go with cesarean delivery. So I think in balance, really, unless there's an obstetrical indication for cesarean section or there's an HIV indication due to inadequate access to care for HIV care, then there would be no added reason at the moment to do cesarean section for Hep B co-infection. Then the breastfeeding issue comes up in situations in which one is advocating for breastfeeding and in HIV-positive individuals, and certainly in parts of the world, that's obviously the first line of infant feeding. As I mentioned earlier, hepatitis B, although detectable in breast milk samples, it doesn't appear to be a primary mode of transmission for hepatitis B, and really rates of transmission seems to be equivalent regardless of mode of feeding, maybe with the exception of cracked or bleeding nipples. So generally speaking, I think that doesn't seem to be an issue of changing recommendations, and in this case, breastfeeding plus ARVs would be ideal, and anti-Hep B ARVs would be certainly optimal in individuals who are breastfeeding with HIV Hep B co-infection. So I'll just sort of summarize by saying that I think in all areas of the world, regardless of resources, we really need to be improving and ensuring that we've got adequate hepatitis B testing in the context of an integrated prenatal program in which HIV prenatal testing would be an appropriate component, that if at all possible, we should be recommending infant hepatitis B immunization that starts immediately after delivery as opposed to a 1-month delay, and if available, HBIG in our Hep B surface antigen positive individuals. Certainly we need to recognize that the Hep B surface antigen woman with the high viral loads may well confer about 20% of post-exposure failure, and this is where selection of anti-Hep B agents in your maternal ARV combinations would be critical. We really need to understand what the impact is of viral mutations that may affect vaccine failures, maybe when one is not on an anti-Hep B regimen, and understanding the future impact of tenofovir exposure in utero and whether TAF is going to alter that issue will be important to understand. And always as new both antiretroviral combinations come out and anti-hepatitis B combinations come out, we're constantly trying to reinforce the need for understanding safety, toxicity, and pharmacokinetic data in women and in pregnancy to try to make future recommendations that make sense. So I think with that I will stop and pass it back over. Thank you.